environment and safety. The learning objectives for this presentation include the following. Discuss nursing responsibilities for environmental safety and management in healthcare and home settings. Identify environmental factors such as noise, clutter, and temperature that affect patient safety and healing. Describe methods to prevent mechanical, thermal, and biological hazards. Explain safe use, application, and legal aspects of restraints and supportive devices. Discuss facility procedures for bioterrorism response, emergency triage, and biohazard cleanup. Demonstrate evidence-based techniques for maintaining a safe and therapeutic environment, including bed making and infection control. When we talk about patient safety and healing, the environment plays a major role, something Florence Nightingale recognized over a century ago. She believed that a clean, quiet, and well-ventilated environment could dramatically improve a patient's recovery. This principle still guides nursing practice today. Temperature should always be comfortable for the patient's condition. Too cold can cause shivering and increased oxygen demand, while too warm can promote bacterial growth or discomfort. Ventilation and humidity are equally important. Poor air quality can spread infection or worsen respiratory distress. Nurses should monitor for drafts, maintain airflow, and ensure filters are clean. Lighting affects mood, sleep, and safety. Adequate lighting prevents falls and helps with wound care and assessments, while dim lighting can help patients rest. Odor control matters as well. Unpleasant smells can cause nausea and distress, so prompt cleaning and proper disposal of linens and waste are essential. Noise is a frequent complaint in healthcare facilities. Alarms, talking, and hallway traffic can interfere with rest and healing. Nurses can reduce noise by speaking softly, closing doors gently, and limiting unnecessary machine alarms. Interior design and neatness may seem minor, but contribute to both psychological comfort and infection control. A tidy, uncluttered room allows safe movement for staff and patients and reduces the risk of falls. Privacy is also a key factor, protected by HIPAA laws. Maintaining privacy through curtains, closed doors, and discreet communication supports patient dignity and trust. Finally, managing all these factors in a healthcare setting is challenging due to constant activity, multiple staff members, and varied patient needs. However, every small adjustment, a lowered voice, a clean workspace, or dimmed lights, supports the holistic healing environment that Nightingale envisioned. When discussing environmental factors, temperature and ventilation are among the most critical for maintaining patient comfort and safety. Infants and older adults are more sensitive to temperature changes and may require slightly warmer rooms, around 68 degrees to 74 degrees, to maintain normal body temperature. Operating rooms and intensive care areas, however, are intentionally kept a bit cooler. Cooler temperatures help minimize bacterial growth and reduce perspiration in the surgical team, which maintains a sterile environment. As nurses, we must always assess whether the patient's environment is comfortable and safe. For example, patients with thyroid disorders, burns, or circulatory issues may not regulate temperature well and may need adjustments in bedding, gowns, or blankets rather than large room temperature changes. Nurses must also consider hospital policy. Temperature settings are often standardized, so small comfort adjustments like adding light blankets or repositioning beds can make a difference. Ventilation plays a major role in infection prevention. Proper airflow helps remove odors, control humidity, and reduce the spread of airborne pathogens. Hospitals use specialized HVAC systems with HEPA filtration to keep air sterile. For this reason, fans are discouraged because they can circulate dust and microorganisms throughout the room. Likewise, windows should remain closed to prevent unfiltered outside air and contaminants from entering. If a patient experiences shortness of breath or requests air movement, a table fan may be permitted only with a provider's order, especially for those with respiratory conditions like COPD who feel relief from gentle airflow. In that case, the fan must have a blade protection screen and be cleaned regularly according to infection control policy. Temperature and ventilation are environmental details that may seem small, but they have a major impact on comfort, infection control, and recovery. Nurses monitor, adjust, and advocate for environmental changes that align with evidence-based practice and patient needs. Humidity refers to the amount of moisture in the air. The comfortable range for most patients is between 30% and 50%, which helps maintain comfort while discouraging microbial growth. When the air is too dry, it can irritate mucous membranes, drying out the nose, throat, and respiratory passages. This increases discomfort and can make it harder for patients to clear secretions, especially those with respiratory illnesses. On the other hand, too much humidity encourages bacterial and fungal growth and can make the air feel heavy or stuffy, increasing the risk of infection or breathing difficulty. Most hospitals maintain humidity on the lower end of this range, around 30–40%, because low humidity helps inhibit the growth of microorganisms and supports infection control. However, this can be uncomfortable for some patients, particularly infants, older adults, or those receiving oxygen therapy. In these cases, humidifiers may be used cautiously according to policy, ensuring the equipment is cleaned properly to prevent contamination. Now let's focus on lighting, which influences both safety and mood. Proper lighting allows patients and nurses to perform tasks safely and accurately. For example, adequate light is needed for reading medication labels, charting, or performing wound care. Dim or uneven lighting increases the risk of falls, medication errors, and eye strain. Lighting should be bright enough for visibility but soft enough to avoid glare and harsh shadows. Equally important is the patient's control over lighting. When patients can adjust the lighting themselves, such as turning lights on for reading or dimming them for rest, they feel more comfortable and maintain a sense of independence. Environmental lighting also affects mood and sleep. A bright, cheerful room with natural light can lift spirits and promote healing, while harsh or constantly dim lighting can lead to fatigue or confusion, especially in older adults. In nursing practice, we balance functionality with comfort, making sure there's enough light for safety and care tasks while preserving a calm, restful environment that supports recovery. When discussing patient comfort and environmental safety, odor control is often underestimated but extremely important. Strong or unpleasant smells can quickly make patients uncomfortable, cause nausea, vomiting, or loss of appetite, and contribute to an overall sense of distress. A clean, odor-free environment not only supports physical comfort, but also promotes emotional well-being and dignity. To manage odors effectively, nurses should empty and rinse bedpans, bedside commodes, and urinals promptly after each use. Fecal matter and urine produce strong ammonia and sulfur compounds that intensify over time, especially in warm or poorly ventilated rooms. Leaving these items uncleaned also increases the risk of bacterial growth and cross-contamination. Dressings, disposable gloves, and wound care supplies should be placed in proper biohazard containers and removed from the room as soon as possible. Odorous materials like soiled linens or old wound dressings should never sit in an open trash can near the patient's bedside. For wounds with naturally strong odors, such as infected pressure injuries, nurses can apply odor-absorbing dressings or activated charcoal filters as ordered and maintain regular dressing changes to minimize discomfort. Environmental sources of odor also matter. Stagnant water in vases or flower arrangements, spoiled food trays, or old linens can harbor bacteria and unpleasant smells. These should be promptly removed. Patients and families should be educated that fresh flowers, while uplifting, should be replaced frequently to prevent decay and mold growth. Another often overlooked factor is personal fragrance. Nurses and visitors should avoid wearing perfumes, scented lotions, or strongly fragranced cosmetics in patient care areas. These products can trigger asthma, migraines, or allergic reactions in sensitive individuals, and they can mask more serious clinical odors that nurses need to detect, such as the smell of infection, wound drainage, or metabolic changes, for example, fruity breath in diabetic ketoacidosis. Maintaining an odor-free environment is a professional nursing responsibility. It demonstrates respect for the patient, supports infection control, and enhances the overall healing atmosphere of the care setting. Noise is one of the most common environmental stresses in healthcare settings, and patients are often very sensitive to it. The main source of noise in hospitals and long-term care facilities isn't machinery, it's people. Staff conversations, visitor chatter, and alarms all contribute to a noisy environment. While we may become used to these sounds, for patients, especially those who are ill, anxious, or in pain, noise can quickly lead to sensory overload, anxiety, restlessness, and even delayed healing. Excessive noise also interferes with sleep, which is essential for tissue repair and immune function. When patients can't rest, they experience fatigue, irritability, and confusion. In critical care settings, constant noise has even been linked to increased blood pressure, elevated heart rate, and stress hormone release. One way to promote a peaceful environment is through sound masking. Gentle, calming background music or natural sounds can help block unpleasant noises and create a more therapeutic atmosphere. Of course, this must be appropriate to the patient population. Some may prefer silence or have sensory sensitivities, so nurses should always assess individual comfort and preferences. To reduce noise, nurses and healthcare teams can make small but meaningful changes. Avoid long or loud conversations in hallways, where sound carries easily into patient rooms. Speak softly at the nurse's station, especially at night or near critical care areas. Respond promptly to IV pump or bed alarms, not only for safety but also to prevent prolonged sound disturbances. Finally, model professional behavior by maintaining a calm, focused tone. Loud laughter, unnecessary talking, or frequent interruptions can seem unprofessional and disruptive. Reducing noise supports both patient comfort and clinical efficiency. A quieter environment allows patients to rest, enhances communication among staff, and helps create a sense of calm and professionalism throughout the unit. Today's healthcare settings are intentionally designed to promote comfort and healing, very different from the stark, sterile environments of the past. Hospitals once used all white walls and bedding to symbolize cleanliness, but research has shown that this environment often made patients feel anxious, lonely, or fearful. Modern healthcare interior design now aims to create a calm, home-like atmosphere that supports both physical and emotional well-being. Patient rooms and public spaces are designed to look more like a hotel or home environment, with warm color tones, artwork, comfortable furnishings, and soft lighting. You'll often see draperies, colorful bedspreads, wood accents, and calming decor that reduce stress and make patients feel more at ease. These features help improve patient satisfaction and have even been linked to faster recovery times and lower anxiety levels. From a nursing perspective, maintaining a healing environment is part of environmental management. Nurses are responsible for ensuring the room remains neat, comfortable, and functional. Small actions, like adjusting the blinds, tidying up bedside tables, ensuring clean linens, and controlling temperature or lighting, can make a major difference in a patient's perception of care. We can think of the patient's room as their temporary home. They need comfort items similar to what they'd have at home: clean bedding, extra blankets or pillows, a phone, access to television or reading materials, and privacy. Nurses should also pay attention to personal touches, encouraging families to bring photos or familiar items when appropriate to promote a sense of security and belonging. Creating a comfortable, home-like environment doesn't mean compromising cleanliness or professionalism. Rather, it means balancing infection control with emotional support. When the surroundings are calm and pleasant, both patients and staff benefit, stress levels decrease, communication improves, and healing becomes the focus. Neatness is one of the simplest yet most powerful ways to promote safety and comfort in patient care. A clean and orderly environment sends a strong message of professionalism, respect, and attention to detail, qualities that help patients feel confident in their caregivers. Nurses and nursing assistants play a key role in maintaining neatness. Straightening the patient's area after making the bed and throughout the shift ensures that the room remains safe and visually calm. Clutter around the bed, floor, or overbed table can lead to accidents and falls, especially for patients with limited mobility or vision problems. Meal trays and dishes should always be removed promptly after meals. Leaving them in the room can create unpleasant odors, attract pests, and promote bacterial growth. Trays should be handled with clean gloves, discarded according to facility policy, and surfaces wiped afterward to prevent contamination. The overbed table is one of the most frequently used surfaces in a hospital room. It often holds personal items, call lights, tissues, medications, and food. For that reason, it must be kept clear of clutter and unnecessary equipment. The nurse should ensure that essential items, like the call bell and water, remain within the patient's reach, but that medical equipment or soiled materials are stored or removed properly. Maintaining neatness also includes attention to dirty instruments and discontinued supplies. Used items like scissors, thermometers, or dressing trays should be cleaned or disposed of immediately according to infection control policy. Expired or discontinued dressing items, ACE wraps, and splints should be removed from the area to avoid confusion and contamination. When the patient's space is clean, organized, and free from distractions, it creates a therapeutic environment that promotes rest, recovery, and emotional well-being. A neat space also helps staff work more efficiently and prevents errors by ensuring equipment and supplies are easy to locate when needed. Ultimately, neatness is not just about appearance, it's an essential part of nursing care, infection prevention, and patient safety. Privacy is a cornerstone of quality nursing care and a patient's right under both ethical standards and federal law, including HIPAA. Preserving a patient's privacy is not just about protecting health information, it's also about maintaining dignity, respect, and emotional safety in every interaction. As nurses, we enter a deeply personal space when we step into a patient's room. Always knock gently before entering, identify yourself, and wait for permission to come in when possible. This simple act shows courtesy, builds trust, and reinforces that the patient still has control over their environment, a vital part of maintaining dignity during illness or hospitalization. In shared or multiple patient rooms, privacy can be more difficult to maintain, but it's still essential. Always draw the privacy curtain or close the door when assisting with personal care activities, such as using a bedpan, changing clothes, or bathing. This helps the patient feel more comfortable and reduces embarrassment. When performing procedures or hygiene tasks, it's appropriate to post a sign on the door stating "Care in Progress" or "Do Not Enter" to alert staff and visitors to wait before entering. These small steps protect both the patient's modesty and your professional boundaries. Maintaining privacy also extends to how we handle personal and health information. Never discuss patient conditions in hallways, elevators, or public spaces. Conversations should occur only with team members directly involved in that patient's care. Think of the patient's room as their temporary home. Enter respectfully, maintain eye contact, and explain what you are doing before you touch or expose the patient. Always close gowns and cover exposed areas during care, revealing only what is necessary to complete the procedure safely. When patients feel that their privacy is protected, they are more likely to trust their care team, cooperate during treatment, and feel secure. Protecting privacy isn't just professional, it's one of the most powerful ways nurses can convey compassion and respect. The hospital bed is one of the most frequently used pieces of equipment in healthcare, and understanding how to maintain it properly is essential for patient safety and comfort. Most hospital beds have a firm mattress covered with a waterproof, wipeable material. This allows for easy cleaning between patients, which helps control infection. The side rails should fit securely and not create entrapment hazards. For example, there should be no gaps large enough for a patient's head or limbs to get caught. Nurses must check that the rails are functioning properly and that the mattress fits snugly inside the bed frame. For patients at risk for skin breakdown, such as those who are immobile or malnourished, pressure-relieving overlays or specialty mattresses, like air, foam, or gel surfaces, can be used to help prevent pressure ulcers. In some cases, specialized beds such as Clinitron R or Stryker R beds are used for patients with complex skin or mobility needs, while bariatric beds are designed for safe care of morbidly obese patients. Safety checks are a vital part of bed management. Always lock the bed wheels when the bed is stationary and keep it in the lowest position when not performing procedures. This prevents falls and injuries. When performing care, the nurse can raise the bed to waist height to maintain proper body mechanics and reduce strain. There are two main types of bed-making procedures, unoccupied and occupied. Unoccupied beds are made when the patient is out of the room, perhaps during a diagnostic test, bath, or therapy. Occupied beds are made only when the patient cannot safely get out of bed. These require teamwork and careful coordination to maintain the patient's comfort, dignity, and safety. Regardless of the type, bed linens should always be clean, dry, wrinkle-free, and neatly arranged. Wrinkled linens can create friction and contribute to pressure injury formation, while disorganized bedding can harbor microorganisms or cause discomfort. When preparing or cleaning a bed, think of it as preparing a healing space. The bed should be safe, secure, and as comfortable as possible, reflecting the nurse's professionalism and attention to the patient's overall well-being. Safety is one of the most critical responsibilities of every nurse. It is the foundation of high-quality care and part of the nurse's ethical and legal duty to protect patients, visitors, and colleagues from harm. The healthcare environment presents many potential hazards, from slippery floors and tangled cords to sharp instruments and electrical equipment, so awareness and prevention are essential parts of nursing practice. The primary goal of safety is to prevent accidents and injuries before they happen. Each time a nurse enters a patient's room, they perform a quick environmental and patient risk assessment, checking for clutter, ensuring call lights and personal items are within reach, confirming bed wheels are locked, and verifying that the patient understands how to use the call system. Common patient accidents include falls, which remain the number one cause of hospital injuries, especially in older adults or those on sedatives. Nurses prevent falls by keeping the bed in the low position, using non-slip socks, ensuring adequate lighting, and performing frequent rounding. Burns can occur from spilled hot liquids, heating pads, or malfunctioning equipment. Always test warm applications on your wrist before use and monitor closely. Cuts and bruises often result from sharp objects or improper transfers. Proper use of assistive devices and good body mechanics reduce these risks. Fights or aggressive behavior may occur in psychiatric or dementia units. De-escalation and maintaining a calm, safe distance are key. Loss of possessions happens when patients move between departments or share rooms, label personal items, and document valuables according to facility policy. Choking can occur when patients eat too quickly or have swallowing difficulties. Sitting patients upright and monitoring during meals can prevent aspiration. Electrical shock may result from faulty equipment or using devices near water. Always check electrical cords for fraying and ensure biomedical safety checks are current. Maintaining safety is not only about prevention, it's also about creating a culture of situational awareness. Nurses must recognize hazards, follow established protocols, and encourage coworkers to report unsafe conditions without fear of blame. Safety extends beyond patients to include healthcare personnel who must use proper body mechanics, wear personal protective equipment, and follow infection control measures to prevent injury or illness. In summary, safety requires vigilance, teamwork, and education. When nurses actively promote a safe environment, they help reduce medical errors, prevent injuries, and build trust with patients and families, ensuring that every person in the healthcare setting feels protected and cared for. Falls are among the most common and preventable accidents in healthcare settings, particularly in hospitals and long-term care facilities. As nurses, preventing falls is one of our most important responsibilities because they can lead to serious complications such as fractures, head injuries, loss of confidence, and prolonged hospital stays. There are 3 major risk factors for patient falls: impaired physical mobility. Patients with weakness, balance problems, or recent surgery are at greater risk because they can't move safely on their own. Altered mental status. Confused, drowsy, or disoriented patients may forget their limitations and attempt to get up without assistance. Sensory or motor deficits. Patients with poor vision, hearing loss, or neuropathy may not recognize environmental hazards or may misjudge distances. Nurses must conduct a fall risk assessment on admission and throughout the stay, using tools such as the Morse Fall Scale. Patients identified as high risk may benefit from a bed or leg alarm, which detects changes in position or pressure and sounds an alert when a patient tries to get up from the bed or chair. These alarms provide an early warning to prevent unassisted movement and potential injury. Beyond alarms, simple, consistent nursing interventions are key to fall prevention. Keep the call light within easy reach and remind the patient to use it before getting up. Always answer call lights promptly. Assist with ambulation to the bathroom, bedside commode, or chair as needed, and encourage the use of mobility aids such as walkers or canes. Ensure the bed is in the lowest position, wheels locked, and side rails used appropriately. Provide proper footwear, such as non-slip socks or shoes, to improve stability. Make sure the environment is well lit, clutter-free, and dry to prevent slipping hazards. Communication and education are just as important as equipment. Explain to patients and families why precautions are necessary and involve them in maintaining safety. Many falls happen because a patient feels embarrassed to ask for help or forgets the instructions. Preventing falls requires teamwork, observation, and anticipation of patient needs. Every nurse plays a part in keeping patients safe, which ultimately protects both patients and staff from injury and liability. Smoking is one of the most significant safety and health concerns in healthcare settings. In most hospitals and clinics, smoking is completely banned to protect both patients and staff from fire hazards and secondhand smoke exposure. However, in some long-term care facilities, residents may be allowed to smoke in designated outdoor areas, following strict supervision and safety rules. The most important rule regarding smoking is that it must never occur near oxygen use. Oxygen itself doesn't burn, but it supports combustion, meaning it allows other materials to ignite more easily and burn faster. A small spark from a cigarette, lighter, or even static electricity can cause an explosive fire when oxygen is in use or leaking into the air. Therefore, oxygen tanks, concentrators, and tubing must be kept far from open flames or electrical devices that might create a spark. In addition to patients, nurses must also monitor visitors and staff compliance. It's not uncommon for patients who smoke to become anxious or agitated when they cannot do so, particularly during long hospital stays. Nurses can help by showing empathy, explaining facility policies clearly, and providing access to smoking cessation support, such as nicotine patches, lozenges, or referrals to counseling programs. Special care must be taken with confused, sedated, or irrational patients who insist on smoking. These individuals should never be allowed to smoke unsupervised because their cognitive or physical limitations increase the risk of burns or fires. Smoking should only occur under direct staff supervision in approved areas, with all safety precautions in place. Additionally, all spark-producing equipment, such as electric razors, heating pads, or frayed electrical cords, must be kept away from oxygen sources to avoid accidental ignition. Nurses should routinely inspect patient care areas for electrical hazards and ensure proper signage is displayed wherever oxygen is in use. Finally, remember that nursing care includes health promotion. Patients and residents who smoke should be given information about the risks of tobacco use and resources for quitting. Encouraging smoking cessation not only supports patient safety, but also improves overall health outcomes, especially in patients with chronic respiratory or cardiovascular disease. In short, smoking safety in healthcare is about prevention, supervision, and education, 3 pillars that protect everyone in the care environment. Patients and residents who smoke should be given information about the risks of tobacco use and resources for quitting. Encouraging smoking cessation not only supports patient safety, but also improves overall health outcomes, especially in patients with chronic respiratory or cardiovascular disease. In short, smoking safety in healthcare is about prevention, supervision, and education, 3 pillars that protect everyone in the care environment. Fire safety is an essential part of nursing care and patient protection. As nurses, we have a legal and ethical responsibility to know how to respond quickly and effectively if a fire occurs in our healthcare setting. Fires in hospitals or long-term care facilities can spread rapidly and are particularly dangerous because patients may be immobile, on oxygen, or attached to life-supporting equipment. Every healthcare worker must know and follow the facility's fire safety policies. This means you should know the exact locations of fire extinguishers, alarms, oxygen shutoff valves, and emergency exits in your assigned unit. You should also know how to report a fire, which often includes notifying the facility operator or security according to the institution's policy. In a fire emergency, always remember the acronym RACE, which stands for R, Rescue. Remove any patients who are in immediate danger first. Your safety comes first, but act quickly to move those closest to the fire away from harm. A. Alarm. Activate the fire alarm system immediately to alert other staff and emergency responders. Time is critical in containing a fire. C. Contain. Close all doors and windows to slow the spread of flames and smoke. This step can save lives and buy valuable time. E. Extinguish. Use the appropriate fire extinguisher to put out the fire only if it is small and safe to do so. If the fire is large or spreading, evacuate and wait for trained responders. There are different types of fire extinguishers, and knowing which one to use is vital. Type A for paper, cloth, or wood fires. Type B for flammable liquids such as oil or gasoline. Type C for electrical fires. Type ABC can be used for all types and is the most common in healthcare facilities. Nurses should also remember key safety precautions when evacuating patients. If smoke is present, stay low to the ground where the air is cleaner and place wet towels across the bottom of doors to block smoke. Have patients cover their nose and mouth with a damp cloth to prevent inhalation injury. Move ambulatory patients first, then non-ambulatory patients using wheelchairs or stretchers if time allows. Fire drills are not just routine exercises, they're an opportunity to practice your knowledge and build confidence. When you work on a new unit, always take a few minutes to locate fire exits, alarm pulls, and extinguishers. Being prepared ensures that you can act swiftly and safely to protect both patients and yourself. Responsibility to know how to respond quickly and effectively if a fire occurs in our healthcare setting. Fires in hospitals or long-term care facilities can spread rapidly and are particularly dangerous because patients may be immobile, on oxygen, or attached to life-supporting equipment. Every healthcare worker must know and follow the facility's fire safety policies. This means you should know the exact locations of fire extinguishers, alarms, oxygen shutoff valves, and emergency exits in your assigned unit. You should also know how to report a fire, which often includes notifying the facility operator or security according to the institution's policy. In a fire emergency, always remember the acronym RACE, which stands for R, Rescue. Remove any patients who are in immediate danger first. Your safety comes first, but act quickly to move those closest to the fire away from harm. A, Alarm. Activate the fire alarm system immediately to alert other staff and emergency responders. Time is critical in containing a fire. C. Contain. Close all doors and windows to slow the spread of flames and smoke. This step can save lives and buy valuable time. E. Extinguish. Use the appropriate fire extinguisher to put out the fire only if it is small and safe to do so. If the fire is large or spreading, evacuate and wait for trained responders. There are different types of fire extinguishers, and knowing which one to use is vital. Type A for paper, cloth, or wood fires. Type B for flammable liquids such as oil or gasoline. Type C for electrical fires. Type ABC can be used for all types and is the most common in healthcare facilities. Nurses should also remember key safety precautions when evacuating patients. If smoke is present, stay low to the ground where the air is cleaner and place wet towels across the bottom of doors to block smoke. Have patients cover their nose and mouth with a damp cloth to prevent inhalation injury. Move ambulatory patients first, then non-ambulatory patients using wheelchairs or stretchers if time allows. Fire drills are not just routine exercises, they're an opportunity to practice your knowledge and build confidence. When you work on a new unit, always take a few minutes to locate fire exits, alarm pulls, and extinguishers. Being prepared ensures that you can act swiftly and safely to protect both patients and yourself. Patient safety is the foundation of quality nursing care. Every nurse, especially practical nurses, plays a key role in identifying and reducing risks that can cause harm to patients within the healthcare facility. One of the first actions a nurse should take is to orient the patient to the unit upon admission. This includes showing them where their call light, bathroom, and personal items are located, and explaining how to call for help. Orientation helps reduce confusion and anxiety, especially for older adults or patients new to the hospital environment. Next, the nurse should assess the patient's gait and risk for falling, along with reviewing their medication regimen for side effects such as dizziness, hypotension, or sedation. Medications like opioids, diuretics, and antihypertensives often increase fall risk. Maintaining a safe environment is crucial. Always keep the bed in its lowest position when not providing care, and lock the bed wheels to prevent movement. Patients should have their call light within reach at all times, and the nurse should respond promptly when it rings. Delayed responses often lead to unassisted ambulation and falls. Encourage patients to use non-skid slippers and provide a nightlight for better visibility during nighttime bathroom trips. Falls frequently occur when patients get up in the dark or rush to the restroom. Nurses should also toilet patients on a regular schedule, especially those with limited mobility or incontinence, to prevent them from trying to get up alone. High-risk patients, such as those who are confused, weak, or recovering from surgery, should be placed close to the nurse's station for easier observation. These patients may require extra supervision, and nurses should remain with them when they are out of bed. To prevent restlessness or confusion, provide diversional activities such as conversation, simple games, or television. Engaging the patient's attention can prevent unsafe wandering or attempts to get out of bed. In long-term care, family involvement can also be helpful for companionship and reassurance. Finally, never overlook the small but vital details. Always check wheelchair and bed breaks, encourage the use of grab bars, and ensure that pathways are clear of clutter and spills. Each of these steps contributes to a safer, calmer environment for patients and ultimately prevents injury. Promoting patient safety isn't just about following policies. It's about applying critical thinking and maintaining constant awareness of potential hazards. As nurses, our vigilance and proactive actions protect patients every shift. When patients transition from the hospital to home, nurses play a critical role in ensuring that the environment supports both safety and independence. Many preventable injuries, especially falls, occur at home, so teaching and assessing for safety risks is an essential nursing responsibility. Begin by emphasizing environmental modifications that reduce fall risk. Encourage the use of non-skid bath mats in tubs or showers, which prevent slipping on wet surfaces. Adding grab bars near toilets and in showers provides patients with stable handholds, particularly helpful for older adults or those with limited mobility or weakness. Adequate lighting is also crucial. Installing night lights in hallways, bedrooms, and bathrooms helps patients safely find their way at night. Poor visibility is a leading cause of nighttime falls. Furniture and room layout should remain consistent. Rearranging furniture may confuse elderly or cognitively impaired patients who rely on memory for safe movement. Clear pathways and avoid clutter to ensure mobility aids like walkers or canes can be used without obstruction. Nurses should also look for electrical and environmental hazards. Extension cords should be removed or replaced with grounded outlets, as cords create tripping hazards. Patients should be warned about toys, pet beds, or animals underfoot that may increase their risk of falling. For patients at high risk of wandering or confusion, door buzzers or bed alarms can alert caregivers when movement occurs, allowing for quick assistance. These safety devices are especially helpful for patients with dementia or post-stroke cognitive changes. Beyond the physical environment, the nurse's role includes education and connection to community resources. Referrals to occupational therapy, home health agencies, or local councils on aging can help patients obtain adaptive devices or home modifications like railings and ramps. Always involve family members or caregivers in safety education. The nurse may assess these actions with them, ensuring they understand how to maintain a safe environment and assist the patient appropriately. Encouraging family participation promotes long-term safety and adherence to recommendations. Finally, remind students that nursing safety interventions extend beyond clinical settings. Promoting home safety not only prevents injuries, it also supports independence, dignity, and quality of life for patients recovering or living with chronic conditions. Biohazards are substances or conditions that can threaten human health through infection, toxicity, or environmental contamination. These include bloodborne pathogens such as HIV and hepatitis B, chemical agents like disinfectants or medications, and biologic waste such as used sharps, contaminated dressings, and laboratory specimens. As practical nurses, understanding how to handle and dispose of these materials safely is a vital part of protecting both patients and healthcare workers. The Occupational Safety and Health Administration, OSHA, sets national standards for managing biohazardous materials in healthcare settings. These standards ensure that every facility has clear procedures for labeling, handling, storing, cleaning spills, and disposing of hazardous substances. You will see the biohazard symbol used on containers for contaminated sharps, laboratory waste, or other regulated materials. This alerts staff to use caution and wear the proper personal protective equipment, PPE. One of the most important tools for biohazard safety is the Safety Data Sheet, SDS. Formerly known as the MSDS, these documents contain vital information about every hazardous chemical in the facility. Each SDS lists the substance's physical properties, health risks, first aid measures, storage and handling instructions, and spill cleanup procedures. Every nurse should know where SDS information is stored on their unit. It must be accessible at all times under OSHA's Hazard Communication Standard. Proper disposal methods are essential. Contaminated sharps should be placed immediately in puncture-resistant red sharps containers, while biohazardous waste such as soiled dressings or body fluids should go into clearly labeled red bags. Never overfill containers or attempt to recap needles. These are common causes of accidental needle stick injuries and potential exposure to bloodborne pathogens. If a biohazard spill occurs, the nurse should follow the facility's protocol, which typically includes wearing gloves and protective gear containing the spill, disinfecting the area with an approved solution, and reporting the incident according to policy. Facilities also require annual safety training for all employees who may handle hazardous materials, ensuring that everyone stays up to date on best practices and regulatory changes. In addition, nurses must be aware of their role in bioterrorism preparedness, understanding how to recognize unusual infection patterns, report suspected biological threats, and assist in community response planning. Ultimately, safe biohazard management is part of a nurse's ethical and legal duty to prevent harm. By maintaining awareness, adhering to OSHA standards, and modeling proper practice, you help safeguard yourself, your coworkers, and every patient under your care. Bioterrorism refers to the intentional release of biological agents, such as bacteria, viruses, or toxins, into a population to cause illness or death. These agents can spread quickly through air, water, or contaminated surfaces, making them extremely dangerous and difficult to contain. The goal of bioterrorism is not only to harm individuals, but also to create fear, panic, and chaos in a community, which can overwhelm healthcare systems and emergency services. Common examples of potential bioterrorism agents include anthrax, smallpox, plague, and botulinum toxin. The Centers for Disease Control and Prevention, CDC, categorizes these into 3 priority levels, A, B, and C, based on how easily they can be spread, their mortality rate, and the level of preparedness needed to manage them. Category A agents, like anthrax and smallpox, pose the highest risk due to their ease of transmission and potential for high death rates. Chemical terrorism involves the use of toxic chemicals to inflict harm. These agents can act rapidly and are often delivered through air, water, or direct contact. Types of chemical agents include pulmonary agents like chlorine gas, which damage lung tissue, nerve agents such as sarin or VX, which disrupt the nervous system and can be fatal within minutes, cyanide compounds, which block oxygen use in cells, vesicants or blistering agents like mustard gas, which cause severe burns and tissue damage. The nurse's role in such events includes recognizing early signs of chemical exposure, using proper personal protective equipment, PPE, and initiating decontamination protocols promptly to prevent further exposure. Radiologic terrorism, or dirty bombs, involves using a conventional explosive to scatter radioactive materials over a wide area. These are also called radiologic dispersal devices, RDDs. The purpose is not necessarily to cause massive casualties, but to spread fear, contamination, and long-term disruption. When radiation is involved, nurses must remember the 3 main principles of protection. Time, minimize time spent near the radiation source. Distance, maximize distance from the source. Shielding, use barriers such as lead walls, concrete, or heavy materials to protect from exposure. As practical nurses, your role during any type of terrorist event is to remain calm, follow the facility's disaster response plan, and ensure your own safety first. Nurses may assist with triage, basic decontamination, isolation of infected patients, and reporting to local health authorities. Communication is vital. Suspected incidents must be reported immediately to supervisors and public health officials to begin containment and response efforts. Terrorist activities are designed to cause widespread panic, fear, and confusion, so preparedness and professional discipline are critical. Nurses who are informed and trained in emergency response procedures play a key part in maintaining safety and helping communities recover from such catastrophic events. When discussing bioterrorism, it's important for practical nurses to recognize which infectious agents or toxins are most likely to be used and how they present clinically. The Centers for Disease Control and Prevention, CDC, classifies biological agents into 3 priority categories, A, B, and C, based on their risk to public health. The agents on this slide are Category A, which means they pose the greatest threat because they spread easily, cause high death rates, and can create significant fear and disruption in communities. Let's look at these major agents more closely. Anthrax, caused by Bacillus anthracis, can infect through inhalation, ingestion, or skin contact. Inhalation anthrax is the most deadly form, leading to severe respiratory distress and shock. Early antibiotic therapy with ciprofloxacin or doxycycline is critical. Botulism, caused by Clostridium botulinum toxin, results in progressive muscle paralysis that can cause respiratory failure. It's not contagious, but small amounts of the toxin are extremely potent, making it a major threat if aerosolized or placed in food. Treatment includes supportive care and administration of antitoxin. Plague, caused by Yersinia pestis, can occur as bubonic, septicemic, or pneumonic forms. Pneumonic plague spreads through respiratory droplets, making it a serious threat in densely populated areas. Prompt antibiotic treatment and isolation are essential. Smallpox, caused by the variola virus, was eradicated globally in 1980, but remains a concern because the virus could be used as a weapon. It causes fever and a characteristic pustular rash. Vaccination is the key preventive measure in the event of exposure. Tularemia, caused by Francisella tularensis, spreads through inhalation, contact with infected animals, or contaminated water. It presents with fever, chills, and pneumonia-like symptoms. It responds to antibiotics such as streptomycin or gentamicin. Viral hemorrhagic fevers, including Ebola and Lassa fever, cause severe bleeding, organ failure, and shock. They spread through contact with infected body fluids. Strict isolation, barrier precautions, and supportive care are required. Finally, ricin is a toxic agent derived from castor beans. It is not infectious but is highly lethal if inhaled, ingested, or injected. Ricin blocks protein synthesis in cells, leading to organ failure. No antidote exists. Treatment focuses on supportive care and preventing exposure. In the event of a suspected bioterrorism attack, nurses play a critical role in early recognition, reporting, and infection control. You must follow your facility's disaster preparedness plan, which includes procedures for decontamination, isolation, and triage. Participate in drills and become familiar with the chain of communication for reporting suspicious symptoms or patterns of illness. Remember, nurses are often the first to notice unusual clusters of symptoms. Staying calm, following protocol, and reporting quickly can save lives during a bioterrorism emergency. During a chemical, biological, or radiologic event, decontamination is one of the most critical steps before a patient can safely enter the hospital environment. The goal is to remove or neutralize hazardous substances from the patient's body and clothing to prevent secondary contamination of healthcare staff and other patients. When responding to such an event, all personnel must wear full protective gear. This includes masks, gloves, boots, and suits made of materials that are impervious to chemicals and infectious agents. Every part of the skin must be covered. Depending on the situation, staff may wear MOPP suits, which are military-grade protective suits designed to block both liquid and vapor chemical agents. A respirator or chemical protection mask equipped with a filtration cartridge must always be worn with the suit to protect against inhalation hazards. Healthcare workers must remember that contamination can spread easily. For this reason, a portable decontamination unit is typically set up outside of the emergency department, staffed by trained professionals. Patients exposed to hazardous materials are decontaminated before they enter the facility. following the emergency response protocol established by the local health department or FEMA disaster response teams. The process usually begins by removing contaminated clothing, which alone can eliminate up to 80–90% of surface contamination. Then, thorough scrubbing and rinsing of all exposed skin using mild soap and water is performed. This is done carefully and respectfully, maintaining the patient's dignity while ensuring safety. Once decontamination is complete, clean clothing or sterile sheets are provided, and the patient can be safely transferred inside for further evaluation and treatment. Nurses must also remember that improper removal of PPE can lead to secondary contamination, for example, touching the outer surface of a glove or mask during removal. Therefore, strict adherence to donning and doffing procedures is essential. The LPN's role during decontamination may include assisting with equipment setup, helping manage patient flow through the decontamination area, providing reassurance to frightened victims, and ensuring that contaminated waste is properly contained and labeled. Lastly, it is critical for nurses to know that all decontamination procedures should follow institutional policy and the Incident Command System (ICS) structure. Calm, organized teamwork, and effective communication are key to preventing chaos and ensuring safety for everyone involved. During a disaster or bioterrorism event, triage and treatment are guided by the principle of doing the greatest good for the greatest number of people. In these situations, medical resources such as staff, equipment, and medications may be limited, so patients must be assessed and categorized by their likelihood of survival if they receive timely treatment. There are 4 standard triage categories used in mass casualty incidents. Immediate, red tag. These patients have life-threatening conditions such as airway obstruction, severe bleeding, or shock, but have a good chance of survival if treated promptly. Delayed, yellow tag. These patients need medical care but can safely wait for treatment without immediate risk to life. Minimal, green tag. These are walking wounded patients with minor injuries such as small cuts or abrasions who can wait or assist others. Expectant, black tag. These patients have injuries so severe that survival is unlikely, even with treatment. In mass casualty events, care for expectant patients may be limited to comfort measures or pain control. This classification process can be emotionally difficult for nurses, but it ensures that limited resources are directed toward patients who have the best chance of survival. This is why, in disaster triage, those with the most severe life-threatening wounds are not always treated first, because they may not survive even with intervention. Treatment is then based on the type of agent, biologic, chemical, or radiologic, and the degree of exposure. For example, antibiotics are used for bacterial infections like anthrax or plague exposure. Antidotes may be administered for chemical exposures such as atropine and pralidoxime, 2-PAM, for nerve agents, or cyanide antidote kits for cyanide gas exposure. Supportive care, which includes oxygen therapy, IV fluids, vasopressors, and monitoring vital signs, is crucial for maintaining organ function while the body works to recover. As an LPN, your role includes assisting in triage under supervision, providing immediate life-saving interventions within your scope, such as airway support, bleeding control, or wound dressing, and preparing medications or equipment for the RN or provider. You may also provide comfort care to those in the expectant category and help maintain clear communication with patients and families. In any mass casualty or bioterrorism event, organization, calmness, and teamwork are vital. Each nurse must know their assigned role, follow established triage protocols, and document care clearly for continuity of treatment and public health reporting. When we talk about poisoning, we're referring to any situation in which a harmful substance enters the body through ingestion, inhalation, absorption, or injection and begins to interfere with normal body function. Poisons can be accidental or intentional and can include a wide range of substances, cleaning products, medications, alcohol, plants, gases, or even biological and chemical agents. For nurses, the first and most important step when poisoning is suspected is to stay calm and call the Poison Control Center at 1-800-222-1222. This national number connects you to experts who will guide you through what to do next. poison control specialists can quickly determine the toxicity of the substance and the safest immediate action. When contacting poison control, always have the product label or container available. Be ready to report the name of the product or substance, including brand and concentration if known, the patient's age, weight, and medical history, since treatment recommendations often depend on the person's size and health condition, the route and amount of exposure, meaning whether it was swallowed, inhaled, or absorbed through the skin, and approximately how much, the time of exposure, and any symptoms the patient is experiencing, such as nausea, vomiting, confusion, or burns around the mouth or nose. One critical point to remember: never try to induce vomiting or give fluids unless poison control specifically instructs you to. Some poisons, especially caustic substances or hydrocarbons, can cause more damage when vomited because they burn tissues again on the way back up. Instead, follow the professional's instructions exactly. Certain substances have specific antidotes, such as naloxone for opioid overdose, N-acetylcysteine for acetaminophen toxicity, or activated charcoal for some ingested poisons. However, treatment should always be guided by poison control or a healthcare provider. In some cases, supportive care, such as airway management, IV fluids, and oxygen, is the priority until the toxin can be metabolized or removed. For nurses in both clinical and community settings, documentation and prevention are key. Always record the exposure details accurately, monitor the patient's vital signs, and stay alert for signs of shock, airway compromise, or neurological changes. Prevention involves educating patients to keep cleaning products, medications, and chemicals locked away, especially from children and older adults with cognitive impairment. Finally, always remind patients and families that poison control is available 24/7 nationwide and should be contacted immediately after any potential poisoning, not after symptoms worsen. Protective devices are often more commonly known as restraints. As nurses, we have both a legal and ethical responsibility to use these devices safely, appropriately, and only as a last resort. Restraints are not used for staff convenience or as a form of punishment. They are used strictly to protect the patient from harm or prevent interruption of vital medical care. There are two major categories of restraint use: behavioral and non-behavioral. Behavioral indications occur primarily in psychiatric or acute behavioral settings, for example, when a patient is violent, combative, or attempting to harm themselves or others. Sometimes this may follow a sudden change in mental status, such as acute delirium or psychosis. Non-behavioral indications are different. These are used to prevent a patient from disrupting critical medical treatments, such as pulling out IV lines, nasogastric tubes, or tracheostomy tubes. In these situations, the goal is to keep the patient safe and maintain essential therapy, not to restrict their freedom. However, the use of restraints always carries risks, especially when they limit a patient's movement for prolonged periods. Long-term use can lead to serious complications, including muscle weakness, atrophy, joint contractures, pressure ulcers, incontinence, depression, and even social isolation. That's why nurses should always explore alternatives before using restraints, such as frequent reorientation, family involvement, low beds, padded side rails, or electronic alarms like bed and wheelchair alarms. If restraints must be used, a licensed provider's order is required and must specify the reason, type, and duration of restraint use. In an emergency situation, a nurse may apply a restraint to prevent immediate harm, but must obtain the order within a short, facility-specified time frame, usually 1 hour. Once a restraint is applied, it becomes the nurse's ongoing responsibility to monitor and reassess the patient at frequent intervals. The frequency depends on the patient's condition and the setting. Behavioral health patients often require checks every 15 minutes, while non-behavioral restraints are checked at least hourly. Nurses should ensure circulation, skin integrity, hydration, elimination, and comfort are maintained. Chemical restraints, such as sedating medications, may sometimes be used to control dangerous behavior, but they must also be prescribed and closely monitored. Remember, both physical and chemical restraints can restrict autonomy and dignity, so use them only when necessary, justified, and properly documented. As a practical nurse, you are accountable for knowing and following your facility's restraint policy and the state regulations that govern restraint use. Always document the reason for restraint use, the alternatives attempted, patient education, and ongoing assessments of the patient's physical and psychological status. By balancing safety, compassion, and respect for the patient's rights, you uphold both the ethical and professional standards of nursing practice while ensuring high-quality, patient-centered care. Let's take a closer look at the different types of physical or manual restraints used in healthcare settings. A physical restraint is any device or method that restricts a patient's movement or access to their body and that the patient cannot easily remove on their own. These devices are used only when less restrictive interventions have failed and when necessary to protect the patient or others from harm. One common example is the mitten or hand mitt restraint. These are soft, padded coverings placed over the hands to prevent patients from pulling at tubes or lines, scratching themselves, or causing injury. They allow some freedom of movement and are considered the least restrictive form of physical restraint when not tied down. However, if the patient cannot remove them independently, they are still classified as restraints under CMS and Joint Commission standards. Next, we have wrist and ankle restraints, such as soft limb holders. These are typically secured to a stable object, like a bed frame, to prevent patients from striking staff, pulling IVs, or interfering with medical treatment. These restraints are considered moderately to highly restrictive because they directly limit limb mobility. Vest or jacket restraints are less common today due to safety risks, but they were once used to keep patients safely positioned in bed or chairs. 4-point restraints are used in emergency or psychiatric settings when a patient is violent or poses immediate danger. All 4 limbs are restrained to prevent movement, and these require continuous monitoring and a provider's order. Posey belts or limb holders are used to keep patients safely seated in wheelchairs or on stretchers without slipping or falling, but they must also be applied under strict safety protocols. Mechanical restraints are devices or equipment attached to or adjacent to the patient's body that cannot be easily removed and restrict movement. While sometimes overlapping with physical restraints, mechanical restraints are often specialized devices designed for behavioral emergencies. Examples include mechanical straps or cuffs used in psychiatric or emergency departments, and restraint chairs or beds. Restraint chairs or beds are used less commonly and generally only in extreme psychiatric or correctional settings under medical supervision. Mechanical restraints require a provider's written order, continuous observation, and strict adherence to facility policy and legal standards. The patient's airway, circulation, and comfort must be continuously monitored. Seclusion is considered a form of environmental restraint rather than a physical one. Seclusion occurs when a patient is placed alone in a locked or secure room and is not permitted to leave voluntarily. This is typically used only in psychiatric or behavioral health settings, and only when a patient's behavior poses an imminent danger to themselves or others. It's important to emphasize to students that seclusion is never used as punishment or for staff convenience. It is a last resort intervention designed to maintain safety and help the patient regain control. From a nursing standpoint, seclusion carries very strict legal and ethical requirements. A provider order is mandatory, and once seclusion begins, the patient must be continuously monitored for both safety and well-being. In most facilities and under federal regulations, the patient's physical and psychological status must be reassessed at least every 15 minutes. This includes checking vital signs, behavior, emotional state, and basic needs like hydration, toileting, and comfort. The nurse's goal during seclusion is to help the patient regain self-control and ensure that seclusion lasts only as long as absolutely necessary. The nurse should use therapeutic communication, reassurance, and de-escalation techniques throughout the process. Remember, documentation must be extremely detailed. Every assessment, patient behavior, and intervention must be recorded. In summary, seclusion protects safety during a crisis, but it also presents an ethical challenge. It requires careful monitoring, compassion, and adherence to legal guidelines to preserve the patient's dignity while preventing harm. When it comes to protective devices or restraints, the legal and ethical responsibilities for nurses are extremely serious. Federal and state laws, along with facility policies, exist to protect the patient's rights and to prevent any form of physical or mental abuse. These regulations are grounded in the Omnibus Budget Reconciliation Act, OBRA, of 1987, the Centers for Medicare and Medicaid Services, CMS guidelines, and the Joint Commission standards. All of these agencies emphasize that restraints, whether physical or chemical, must be used only as a last resort. The law requires that every patient be protected from unnecessary restraints. This means nurses must first try all possible less restrictive interventions, such as verbal de-escalation, environmental modifications, or increased observation. If those measures fail and restraint use becomes necessary, the law mandates that it must be authorized by a licensed provider in writing and for a limited, specific duration. The order must include the reason for restraint use, the type of restraint, and how long it may remain in place. In emergency situations, when a patient poses an immediate threat to themselves or others, a nurse may temporarily apply a restraint to prevent harm. However, the nurse must notify the physician immediately and obtain a written order as soon as possible, often within 1 hour depending on the facility's policy and state law. The Joint Commission supports the use of restraints only when they are clinically justified and absolutely necessary to protect the patient's safety or the safety of others. Restraints are never to be used for staff convenience, punishment, or as a substitute for appropriate nursing care. Misuse of restraints constitutes patient abuse and can lead to legal action, disciplinary measures by the Board of Nursing, and loss of employment or licensure. Only trained, licensed, and qualified personnel may apply restraints, and they must follow facility protocols carefully. Ongoing monitoring and documentation are critical. Nurses must continuously assess circulation, skin condition, comfort, and the patient's physical and emotional status. Every assessment, including any attempt to remove or reduce restraints, must be documented accurately. In summary, your role as an LPN is to understand and follow both the legal mandates and ethical principles behind restraint use. Always prioritize patient safety, dignity, and autonomy, and remember that the best form of restraint is prevention, using good communication, observation, and compassionate care to avoid escalation. Before we ever use a restraint or protective device, our first priority as nurses is to find safer, less restrictive alternatives that keep patients safe while still maintaining their dignity, comfort, and independence. This is not just good practice, it's an ethical and legal expectation in healthcare today. Both the Joint Commission and Centers for Medicare and Medicaid Services, CMS, emphasize that restraints should only be used after all other interventions have failed. The goal is always to move toward a less restrictive environment. For example, instead of using wrist restraints to prevent a confused patient from pulling at an IV line, you might try securing the line out of sight, using a soft sleeve cover, or reorienting the patient frequently. Sometimes simply modifying the environment, such as lowering the bed to floor level, ensuring good lighting, or reducing noise, can reduce restlessness and agitation. Frequent observation and reorientation are among the most effective alternatives. Checking in with patients regularly not only promotes safety, but also decreases their anxiety and sense of isolation. For patients at risk of falling, consider using a better chair alarm, a non-skid floor mat, or ensuring the call light is within easy reach. These interventions promote safety without physical restriction. Involving family and friends can also make a tremendous difference. A familiar voice or presence can reduce confusion and agitation, especially in older adults with dementia or delirium. Encouraging a family member or volunteer sitter to stay with the patient provides reassurance and helps prevent unsafe behaviors. Other strategies include providing diversional activities, for example, folding towels, listening to calming music, or watching familiar programs, and addressing unmet needs like hunger, thirst, or pain. Sometimes what appears to be unsafe behavior is really the patient's way of expressing discomfort or fear. By using these alternatives, we not only prevent injury, but also reduce the emotional trauma and physical risks that come with restraint use, such as pressure injuries, decreased circulation, and muscle weakness. As nurses, our goal is always to use our critical thinking and compassion to meet the patient's needs in the safest, least restrictive way possible. When we talk about the principles related to the use of protective devices or restraints, we're emphasizing the nurse's legal and ethical responsibility to ensure that these devices are used safely, correctly, and only when absolutely necessary. The main purpose of a restraint is to protect the patient, not to control behavior or make care easier for staff. Every decision must balance patient safety with respect for autonomy and human dignity. A restraint should only be used when it is essential for the patient's medical care or safety, such as preventing the removal of life-sustaining equipment or ensuring safe recovery during confusion or agitation. Whenever possible, nurses should apply the least restrictive form of restraint. This means using a method that limits mobility as little as possible while still protecting the patient. Perhaps a soft wrist restraint instead of a vest, or a family sitter instead of a physical restraint. Federal law requires a written order from a licensed provider before applying any restraint, and that order must specify the reason, duration, and type of device. If the patient's condition changes and the restraint is no longer needed, it must be removed immediately, and the physician must be notified. Using a restraint without authorization or for convenience could be considered false imprisonment or even patient abuse, which has serious legal consequences. When applying a restraint, nurses must ensure it's snug but not tight. The device should never restrict blood flow, compress nerves, or impair breathing. A quick test is the two-finger rule. You should always be able to slide 2 fingers between the restraint and the patient's skin. After application, inspect the area for redness, swelling, skin breakdown, or coolness. These can be early signs of impaired circulation or nerve pressure. The patient's position and safety must be reassessed at least every 2 hours, and more often if the facility policy requires it. During these checks, the restraint should be removed briefly so that the patient can be repositioned and perform range of motion exercises. For example, if a patient is restrained at the wrist, gently flex and extend the fingers, wrist, and elbow. This prevents joint stiffness, atrophy, and circulation problems. It's also a time to assess hydration, elimination needs, and emotional well-being. Movement and mobility are essential for both physical and mental health. Patients who are up, active, and appropriately exercised during the day often sleep better at night and are less restless or confused. Promoting even small amounts of mobility, like sitting up in bed or transferring to a chair, can reduce the need for restraints altogether. As nurses, it's our duty to use critical thinking before and after applying a restraint. Ask, is this still necessary? The goal is always to remove the restraint as soon as possible and to restore the patient's independence safely. Proper documentation should include the reason for use, type of restraint, assessment findings, care provided during restraint, and the patient's response. By following these principles, we maintain both patient safety and professional accountability, which are at the heart of ethical nursing care. Nursing skills to review in the text include making an unoccupied bed, making an occupied bed, and applying a restraint or supportive device. This ends the presentation. Thank you.